Starting off this afternoon's presentations, we have a presentation on a model for supporting clinical monitoring for ALD newborn screening. Please join me in welcoming Dr. Laura Adang from Children's Hospital of Philadelphia.
Thank you, guys. I have the illustrious honor of speaking to you when you are exhausted and now overfed. So I'm going to talk to you today about two things. First of which, I'm going to talk about our newborn screening program at the Children's Hospital of Philadelphia and how we have implemented a system to track our children to make sure no one is lost to follow-up. And then the other thing is I'm going to talk a little bit about how we can use real-world data, such as collected through these types of programs, to really do some very informative research. I do have some disclosures, including some pharmaceutical collaborations that we have. NIH has funded the work I'm going to talk about today, and we have several family foundation fundings as well. I have a lot of patient photos in here, all with permission from the families. This is my third talk this week, and I'm not going to give a single talk without putting this up on the screen. This is a transformative moment. Yeah. Because it shows that gene therapy for leukodystrophies is not a fluke, right? It was not ALD is special. It's that these are fundamentally treatable disorders when we jump in there in time. And so I think we are on the beginning of a wave of revolution on how we need to care for these children, how we need to create therapies for them. I am lucky to work at CHOP, and that's part of the large leukodystrophy clinical trial network, or GLIA-CTN, which has sites around the country. Many of the providers in our trial are actually here today, so a lot of the ALD centers are part of it. And within the CHOP Leukodystrophy Center, this is who is in clinic with us on a Thursday. This is my clinical team and our research team. We have 4 leukodystrophy doctors working simultaneously. We fully integrate research and clinical care. So this is a big group. We fill our rooms. We have been helping to manage children with adrenal leukodystrophy for decades, but really in earnest when newborn screening was rolled out in PA, which was April of 2017. And I saw all of these boys as they were first diagnosed, and I could keep the first 5, maybe 10 in my head, and when they needed their screening done, when it needed done. And then I moved to a really painful spreadsheet process, and eventually it just got too complicated. ALD has changed the paradigm of how we do newborn screening. It used to be you got a diagnosis, you did an intervention. That was what was on the newborn screening platform. And now we're in an era where ALD and other newborn screening disorders have different phenotypes. They have variable ages at intervention, and some children we identify through newborn screening might not even have an intervention that we're going for. And this has created a new and complex problem that, I will be frank, the medical system is not entirely ready to handle, where we have someone who's diagnosed and we need frequent, very regimented monitoring and follow-up, not for a month or 2, but for 18 years until we transfer them to an adult provider. That is paradigm shifting. We benefit from ALD, many of the beautiful guidelines that were developed by people in the room, right? And so I know what to do. It's unfortunately really complicated, both for the providers as well as for the families. And so how do we make sure that every child is getting the care they need in the proper sequence and frequency? So because of this growing need, as we were finding more and more boys within our catchment area that needed to be monitored, I was talking to my mentor and friend, Adeline Vanderver, and I said, Adeline, what can we do about this? And she said, well, actually, CHOP has a quality improvement program that is integrated within our electronic health record system, which is Epic. They might be able to help you. So I spent the next 9 months working with the lovely Betsy Brooks, who leads our Healthy Planets team at CHOP. And I started off with saying, look, even at diagnosis, we have a problem. Children are getting referred to metabolism, and then they need to get to neurology. How do I know I'm seeing 100% of the boys? We, even within the first week of life, have the potential of losing people that just don't understand or don't want to follow up. We have a gap in monitoring because of non-compliance. Our medical system is built to flag abnormalities from results. It is not built to flag that I didn't get a result in the first place. So how do I track kids that aren't showing up? And then the last is that these are complicated guidelines. They are clinically informed, they're really good guidelines, but how often I need to monitor for things changes with age, and that's a hard problem. And so Betsy and I would sit down and I would meet with her for several hours a week as I'm just like, okay, this is why ALD is really important. This is why it is medically necessary I catch these boys in time. But look at what I'm trying to manage on my own. And it was taking me hours, sometimes days per month to make sure no one was falling through the cracks and causing, honestly, quite a few of my gray hairs. How do we capture what is not happening? And so Betsy said, I think Healthy Planets can actually work for this. It is an electronics health records registry program. And I said, I need it to capture every single person that has been seen at my hospital, which is CHOP, who has an ICD-10 code consistent with ALD. But guess what? I also want to be able to manually add patients, just in case I know of someone that's not coded right, and I want to be able to manually take them away in case they got to treatment or transferred care to another institution. I also wanted a warning system that not only told me when I was late or had a result, I really wanted to know when I should be reaching out to the family to prevent problems. So I asked for a 3-tier color system, which also tells me when the child is within 3 months of needing it. She looked at me really long and was like, I think I can do it. And this is just a testing module of what we have. And you can see here, these are 4 fake patients. I have dates of birth, I have age and sex, MRI status. It tells me when the last MRI was completed within our system. If it was completed outside of CHOP, I actually have a manual system where I can enter the date. It tells me when the next MRI is actually scheduled. And it also, I was finding a lot of times my orders were expiring, so children were having trouble getting it scheduled or completed. I even put a when are my orders expiring thing. And I did the same thing for endocrine testing, ACTH, cortisol, even HLA testing. I wanted to know which of my children had HLA testing. And so if we look at an example of this child here has a yellow flag, which means within the next 3 months, they are going to be due for testing an MRI. And once it gets scheduled, it turns to a little green. It's a really simple system, just meant to show me not what the results are, but have I lost anyone and who do I need to reach out to? And in fact, each one of those little colored flags actually stands for a numeric value or a categorical variable, so you can sort by it, and I can actually batch select every single child that's yellow, and up here, send a communication, and I send a generic message to every single family that says, hey, just giving you a heads up, your MRI is due to be scheduled. You haven't scheduled it yet. Please get that done, right? And so now I'm messaging not every single family individually, but 20 or 30 families at the same time. And my children that have red flags, I then can batch message my social worker or my nurse and say, please reach out to these families and find out what the barriers are and why they aren't following up the way we need to. It is taking what used to be a day-long process per month and a lot of stress, and I can do it now in 5 minutes, right? It's game-changing, to the point we've rolled this out across the metabolic disorders that have this long-term follow-up need at CHOP. And so how are we doing? It's the same. So in triangles are our boys with ALD. This is their MRI monitoring compliance. If it's an open figure, then they got it within the recommended guidelines. It's red if they got it late, more than 10% late, so just a little bit late. In the circles are after I implemented Healthy Planets. And it's the same. Some families are late, some families are not. But the difference in my time is days versus 5 minutes. And I'm doing just the same. And I'm not stressing in the same way because I have a lot of safety nets. I've in fact caught 2 boys that were referred to my clinic and the family never made an appointment. We were then able to reach out to metabolism and social work and find them again. And so it allows you to find things you didn't know you were missing. I was casually talking to a couple of NIH officers about this at a meeting, and they were like, oh, you should apply for a supplement. So we got NIH funding to roll this out across several of our GLIA CTN sites. I see many of the people here that are going to be implementing this same program, and we'll see how it translates across institutions. So I'm going to pivot now, because there's only so much I can talk about an electronic health monitoring system, and talk about what we can do with this kind of information. And actually, the second part of the NIH grant was to see the power of this kind of information as we're harnessing electronic health records and translating it into research aims. It's really important. This real-world data has incredible value and can supplement prospective natural history studies and sometimes even better them or supplant them. I see Tim smiling there. Hi, Tim. We have to get ready for a revolution. These leukodystrophies, we have a revolution in diagnosis, in treatment, and care for both our symptomatic and pre-symptomatic families. I got asked to write a book chapter on the leukodystrophies. I'd recommend to any of the junior trainees, don't do that. It takes a long time. This is the list of leukodystrophies. It used to be 8. We're now over 200. These are the ones that are in clinical trials now or very soon. This list is growing and I think is out of date because I did this about 6 months ago now. So a lot of our disorders, again, were fundamentally untreatable, difficult to diagnose, and we are in a revolution where we are now diagnosing earlier, better, and treating. This is another image where, you took what was thought of as the old school types of leukodystrophies, and all of them have treatments either that are approved or in process. And I apologize, I made this a little bit before. Again, Len-Meldy is approved in the United States now. So how do we use this kind of information that we're pulling from electronic health records or even just medical records and apply it to inform our understanding of these rare diseases? First off, you can use this type of information as a non-concurrent control cohort for clinical trials. When done rigorously, you can map neurologic function in a population just using medical records. And we did so with our MLD cohort for Takeda SHIP 611, where we matched inclusion criteria in our natural history cohort to the children that were included in the trial, and then longitudinally mapped what their neurologic function was. You can capture a moment that until newborn screening we can't capture, which is what happens before you're diagnosed, which is really when children are presenting and potentially are amenable to intervention. And you can do evidence-based guideline development through this real-world data as well. So cute, I know. We took our AGS cohort of close to 200 children and extracted key medical events that were just noted in their medical records. When did they have thrombocytopenia? When did they have anemia? When did they have a G-tube placed? And we can map this longitudinally and then look at different variables in AGS, such as the different genotypes or microcephaly or age at onset, and do stratification by this to identify different factors that make events more or less likely. This means currently in AGS, for all the AGS doctors out there, we monitor everything for everyone all the time. It is a systemic disease that is quite complicated to care for. But if we can start to identify variables that help us limit or define or personalize these care guidelines, we're going to decrease the burden on families significantly. For TUB4A leukodystrophy and metachromatic leukodystrophy, among others, we've mapped early development by looking at the early records before the child was diagnosed. At 6 months, did the pediatrician's note talk about sitting? At 9 months, did the family present saying, I'm worried about my child not pulling to stand, but at 10 months they were? This is information that you really can't capture at the moment of diagnosis. The family is in chaos. They don't remember these things. It feels overwhelming to remember those little moments. But those little moments are the most important for us to identify who needs intervention and when. So in TUB4A leukodystrophy, we collected early developmental milestones. And here's a developmental milestone heat map, where the warmer the color, the higher percentage of the population has attained a milestone at a given age. And we, through this, actually identified novel subtypes or disease trajectories, and we're going to use this to inform upcoming clinical trials where we can identify clinically coherent cohorts of children where we can predict what their developmental pace is going to be, and then show that any interventions are beneficial. In MLD, we've done a similar approach looking at 17 different developmental milestones. Again, prior to diagnosis, just looking in the real-world records to find out when milestones were attained. And we find as early as 6 months, children with MLD who have the late infantile form have a difference in their development. This means I don't want to wait until 18 months when they have truly failed to walk to do the intervention. I want to give gene therapy as soon as the child meets the weight criteria, if I am certain they have the late infantile MLD. And so this is real-world data that is informing our clinical practice. And finally, one of my favorite uses of this is we have used real-world data in an ultra rare disease where there are probably 45 children living in the world, multiple sulfatase deficiency. And by allowing every single family, even those that have lost their children, to contribute all of the medical records, we are able to get meaningful data from exquisitely rare disease. And because of this, we actually have 2 clinical trials that we'll be launching hopefully within the next year or so. One in Europe as a small molecule retinoid, which we believe activates the multiple sulfatase deficiency gene and makes it slightly more effective. And we also got a bespoke gene therapy, AAV therapy, to replace the missing gene in this population, entirely based on our retrospective real-world data. So in brief, we used the existing medical records, mapping out gross motor function, swallowing function, and expressive language function, and we're able to define cohorts of children that either walked or didn't walk, follow them across different outcomes, like how did the children that failed to walk do with swallowing function? Not surprisingly, they all needed early G-tubes. And interesting things like expressive language, meaning speaking. Really across the board, most of our children with MSD had difficulty with speaking, and therefore that really wouldn't be a good outcome for a clinical trial because it's just not a skill that is even attained in this population. We did the same thing looking at systemic complications in this population, and we used this information to inform an ongoing prospective natural history study where we're going to confirm it. But if we didn't have this foundation, I would not have known that a sizable percentage of our children have hydrocephalus. And guess what? We would have blamed the hydrocephalus on the gene therapy product, right? And so it's information gathering every single moment in time you possibly can to make the most meaning of the gift the families are giving us when they enroll in our natural history studies and trials. So in summary, hopefully you agree real-world data can be a really powerful supplement to a traditional prospective natural history study. It doesn't replace it, but it certainly can fill gaps with higher numbers and different information. I hope you like the registry that we have built for ALD. I love it. I'm going to be building our MLD one soon in anticipation of our hopefully someday RUSP approval. And I'm using these registries to track this information, but for our consented families, we can pull that information, and we're going to work with Eric Malik, who's going to see, do these types of programs improve compliance, decrease loss, and dropout? And we can use this real-world data to fill gaps in our understanding by mapping the neurologic function in a time point we normally can't capture, which is before diagnosis. And when done in a certain way with regulatory rigor, you can even use this type of data as a non-concurrent control in clinical trials, meaning children won't necessarily have to get placebo or be randomized to placebo arms. We are using this data to identify early stratification biomarkers. So when I meet a child identified through newborn screening, I know how to say with more certainty, you have these features, therefore you're likely to be an earlier onset, and these are the complications that I would anticipate. So we can do much more preventative care rather than just reactionary medical care. Oh, here comes my advocacy mom taking a picture of me. So in summary, we have a large group of wonderful collaborators from around the world that have helped us to collect a cohort of really unprecedented numbers of children affected by rare disease, and we're using this information as best we can to map function to the ends of developing better care, better treatment, better diagnosis. So thank you very much for your time.
Thank you. That was great, and I definitely hope that we'll be getting this program. I just had two questions. The first is, are you able to adjust that program when you change your recommendation? So when you say have someone transplanted and now you're going to change it, or when you're on like a 3-month monitoring? And then my second question is, I think at the end of the day, the big thing is, how do we change the compliance? And this is where our group has also, in Boston, has also had trouble, where, you know, you have like 2 or 3, you can, you know, short of us showing up at someone's house, it's, you know, we've tried calling primary care doctor, sending certified mail. At some point, it's very difficult to know how to make sure those boys are getting access. And I don't know if your group has ideas on how to close that, because as much as we all want to save time, obviously that's the primary goal.
Yes, you are going to get the program. And I'm happy to share, it's not proprietary. I made it up out of a clinical need, and I'm happy to share all the information I can with anyone that wants it. I think it has, for me, been invaluable. It lets me know when families are not compliant and helps me reach out to them. It doesn't fix the fundamental barriers as to why some families are not compliant. And I think that is a really complicated question, and I don't have a great answer. I struggle with that. I think most families are fine when I call them and remind them, but there are some families that are really in a moment of trauma or shock and aren't ready to hear that information. To that end, I do have a grant from the Legacy of Angels to implement a resiliency training program for families, where they just moved to, it's called the PRISM program, and they just moved to Boston Children's, so they're in your neighborhood. And so there are ways to help families cope and adjust to difficult information. I don't think any of us could pretend that this isn't just life-changing information, even if it is also life-saving information. And so making sure we have those social supports and infrastructure to support families and meet them where they are, I think it's going to be a long-term solution, but one that's worth us rallying together.
Great talk, Laura. I can't wait to use some of the tools you're building here. Two quick comments. So I love working with real-world data, and comparing across the leukodystrophies is exciting. There are also always things where I have to check myself, because we can have huge slips as we do that. Genotype-phenotype correlation is not the same as in MLD. So, you know, just want to make sure the families understand it's not just a matter of waiting till there's a certain weight reached for the ALD boys, as you might do with a late infantile MLD kid, right? And then I guess the second thing is the adults, you know, the mothers, the uncles. I know you're a children's hospital. How are you managing that, and are you working with Penn? And, you know, I would love to learn how to do that better as we're trying to take care of the families.
Thank you, Florian. It's a pleasure collaborating with you as well. And I'm sorry, I forgot to answer one of the questions. Yeah, it's completely customizable, right? You build it in as guidelines change, you've changed the flagging systems. I wanted it as simple as possible, so I didn't get overwhelmed with columns. I didn't even go into it, but you can click on each individual line or row, which is a patient. It will then display both tabular data on, say, what their adrenal replacement regimen is, also graphical data on what their ACTH and cortisol is over time. So all of that can be built in and just customized and adapted over time. It is unfortunately not something that you can just share a code for, because each institution, even using same EPIC, it needs to be individualized and programmed, which is why I'm happy to share this information with you, but you really need an institutional person capable of doing this programming. To Florian's point, which I'm trying to avoid because I think it's a really complicated and important question, is how do we support across the lifespan? I think it's much harder. At CHOP, we partner with Jen Orthman-Murphy, who trained with Ali Fatimi, and so she's at Penn. And so she will sometimes see patients with us. We will have release of information and be able to talk very freely between institutions. It's hard though. I think there's not the same social supports and infrastructure in an adult hospital compared to a pediatric hospital, which is where I think getting to how do we support the whole family becomes really important, because I think even though we have a long ways to go in pediatrics, we have, I would say, an even further way to go in adult medicine. So I'm sure some of our adult AMN patients have strong feelings about this too.
So Dr. Adang, as MLD moves into this wonderful space of having an FDA-approved therapy, I can't stop saying that, and newborn screening, what opportunities for collaboration across the space, given that the ALD community has been a leader in this space for so long, what opportunities for collaboration do you see with Krabbe, MLD, so we are stronger together, and providing, in particular, the role for the patient advocacy groups to support newborn screening families in a way that is respectful of their different journey, and helping maybe even address the non-compliance issue you're seeing in your clinic?
I mean, that's a beautiful question, Maria. I would be happy to open that up to the group too if they have thoughts to follow up on. I mean, I think we do need to share from each other. I'm an MLD doctor. I am also an ALD doctor and a Krabbe doctor, and I see children with all different types of leukodystrophy, and that's true for most of us in the room who are providers. But yet we have very siloed advocacy organizations and so much to learn from each other. I think it's an honor to be here in the ALD space. I learned so much from you, and then I immediately steal it and bring it back to, to the other communities, which is a wonderful thing. But guess what? Every single one of my Krabbe families would love one of your care packages too. They are going through something just as scary and traumatic. And our MLD families, once we have that added to the RUSP and newborn screening, they're going to need those care packages too. So I think the more we can realize we have more things in common than we have different between the leukodystrophies, I think which treatment we use and when we use it, totally disease specific. But the trauma and the stress the families are going through is honestly a very shared moment. So does anyone else have something they would like to add to that? Because I think this could be a good group discussion on how other institutions are helping families deal with this.
I was just going to say, mine is a question, so Dr. Regelman, if you were going to contribute to that, you should.
Mine was more of a question / comment, and this is a beautiful program that you're presenting, and you work in a very well-funded hospital, and I have a decently funded hospital, but not CHOP, and my EPIC is a stripped-down model, and most people have EMRs that are kind of stripped down and do not have this. I logged in, I'm like, do I have Epic Planet? I don't. But I have there are other things that are like low-hanging fruit for people, and I think this is the point of sharing with everyone. There are things that in my stripped-down model of Epic that I have, that if I have the patient on my schedule, I get alerted if they cancel the appointment. I get alerted if they don't follow through with their radiology study, as long as I remember to click the box saying that they have to get it done within 6 months or whatever it is that my expectation is. So I get alerts when things aren't done, as long as I make sure that it's scheduled at the time I'm closing the chart. I do not get notified if someone's never come to see me, though. And that is a very unique thing, which I think is good. But I think the point is that a lot of us all over the country are doing different things to try to follow up kids and find them and meet them where they are and to get them into care. And there are lots of things just outside of even the leukodystrophy community that we can learn from people in our own institutions and outside of them.
I think that's a beautiful point. I wonder if that's a place too that the advocacy groups can step in with funding potentially to fund institutions that are seeing a large number of children identified through newborn screening and can get this module added on, because they are units, and some institutions don't house the Healthy Planets programmers in the way CHOPT does, but rather use contractors to come out. So it seems like something that could be potentially a small grant to get funded. And I'm happy to share all of the programming and Betsy as much as I can promise her.
Okay, this is super cool, and I'm so excited about this. I have a very specific question. When you can go in and send out the email blast to the ones who haven't come in, so is that going to an email address that the patient's family filled out upon the first time they came to see you?
Yeah.
And is it asked for again? I'm just amazed from our side, and obviously we're dealing with much less families than you are, but how much these families move and get different email addresses and home addresses, and I'm just wondering if it's asked for again in the beginning, in those initial appointments, if there's a change in contact or something like that.
Yeah, so I called it email to make it simpler. It is actually the login portal for CHOP. So
Okay.
it is connected to their email, but it is with an app that is for our institution. And so it is a one-time thing. Families can update it. And we also call and send certified mail, and I will find my families. But it means that I'm now trying to track down one patient per year,
Right.
I spent a lot of time before I implemented this, making sure I wasn't losing someone by accident, that maybe had transportation issues getting to my institution or was so scared and overwhelmed they didn't want to come, right? I think lots of families have very good reasons for being less compliant. And then hopefully with this kind of information, which we will pipeline to Eric Malik, he can help to develop more evidence-based guidelines that really inform the frequency of how much we are testing, because we are oftentimes asking more than we need to with families, right? We're very conservative at the beginning, and the goal is really to make much more personalized or customized guidelines in the future. Give us time. We're not there yet.
Oh yeah, no, I'm just trying. My mind's going because I'm so excited about it. I'm thinking too. Well, could we add the pediatrician onto that list too? It's just so exciting. So the questions come from a place of humbleness, and I just can't wait to see what comes from it. So thank you.
Well, thank you very much for having me.